I work as consultant child psychiatrist at Horsham Camps. Today I'm here to have a chat about psychosis. So first of all, I just would like to start with a little disclaimer. I have not trained here, so I'm not fully sure of your level of knowledge at this specific stage. I try to gather some intelligence from my CT trainees to have information from them. But if you think that this is too basic or irrelevant or too confusing, please let me know through the feedback at the end. It will be helpful for me to improve the presentation or change a little bit the way I teach. So as said, today we have an ambitious task. We should cover the topic of psychosis in an hour, actually a little bit less now. In the index, I tried to incorporate all the sections I felt it's important to cover. Hopefully, we will have enough time to cover all of them. But let's see how we get on. And if there is anything that is unclear, please pop it in the chat. Anita, I will ask your help here. In case I don't notice things in the chat, please let me know so that I can minimize my screen and have a look at the chat when questions pop up. I'll try to leave a few minutes at the end in case you have questions. Yeah. So let's start. First of all, I think a definition of psychosis would be helpful. So psychosis is a mental illness that is typically characterized by severely impaired functioning and radical change in how a person presents, and that's due to a distorted or not existent sense of objective reality. That's the hallmark of psychosis. Generally, psychosis is thought of as the defining feature of schizophrenia and schizophrenic spectrum disorder, but is actually a combination of disruptive symptoms and a common presentation of many developmental and acquired or degenerative neurological and medical conditions. So today we'll look at it from the clinical point of view, which kind of sign you will have to detect, which kind of sign will help you to make a differential diagnosis. Across these conditions, so all the conditions that you can see in the slide, psychosis is always a contributor to disability and also a barrier for the individual to function properly, but also have a decent well-being and participate to normal life in society. So as such, across the board is an important target of evaluation and treatment, not only in psychiatric practice, but also in neurologic practice and all medical fields. So, as you might know, there are different systems and organizations which are involved in defining illnesses systematically, both in medicine and psychiatry. So, before we go into it, I would like to make a little step back. So, what's your knowledge? What's your conception? Which are, in your view, the main signs for psychosis? Which are the ones that you know already and you are aware of? Can you pop? I'm sure that some of you are still awake, so if you can pop something in the chat, that would be helpful for us to make a start. I can't see any. Oh, I can see something now. Somebody has been brave enough. Can you hear me? Can you hear me?
I certainly can, yes.
Okay, right, great. So I'm sure that some of you is awake, guys. So would you be so kind to put the sign and symptom of psychosis that you know in the chat? So somebody say that, okay. Positive and negative symptoms. Positive symptoms may include hallucination or delusion. Thank you, Joshua. At least one person is awake. That's great. And that's right. Okay, great. So let's continue. Let me put it as screen. So as Joshua helpfully suggested, the hallmark, the signs and symptoms that are distinctive of psychosis are delusion, hallucination, disorganized thinking and speech, grossly disorganized or abnormal motor behavior, including catatonia, and negative symptoms. We will go into each one a little bit more in the next slides. There is another widely used system, which is the American Psychiatric Association system. And also, obviously, there is the definition from the World Health Organization. They are very similar, so I put them together. In those systems, for a diagnosis of psychosis, three main things are required. The presence of hallucinations without insight into their pathologic nature, delusions, and both hallucinations without insight and delusions. So in both of these current diagnostic classification systems, impaired reality testing remains central conceptually to psychosis. The prevalence of this condition in UK was estimated in 2016 as 0.7% in general population above 18. So it's not that rare. It's a disorder, it's a condition you might come across too. So it's important you recognize the symptoms and signs. Another way to define them is, as Joshua suggested, categorizing them in positive symptoms and negative symptoms. So the positive symptoms describe experiences that are not usually present. So it's something more, it's something added. For example, an example is the hallucination. So people hearing or seeing things that other people can't. Or a thought disorder. So people not thinking straight and therefore they are doing loose association, which are very difficult to be followed. Negative symptoms describe a lack or a loss of an experience that is normally there. So loss of motivation is an example, loss of pleasure or anhedonia is another. Withdrawal from relationship and activities is a third one. The difficulty with negative symptoms is that although they account for an important portion of the disability that is implied in psychosis, they are very difficult to detect at the early stage. They are often mistaken for a sign of mood disorder. And in other cases, they are detected at a later stage. So they are all kind of associated with the use of medication rather than being a primary symptoms of the condition. In the picture above in the corner, I put this picture because it's helpful in terms of understanding why these symptoms happen. We will go into more details later. So positive symptoms are linked to imbalance of dopamine in the mesolimbic area, which is the area that integrates sensory experiences with other information. Therefore, in this case, it creates these symptoms, and it's a perception that is non-linked to the stimuli. In case of negative symptoms, there is a hypofunction of the mesocortical and prefrontal cortex, leading to all the symptoms we have described. So lack of energy, lack of pleasure, withdrawal from relationship and activities. As I promised, let's go into a little bit more detail regarding these symptoms. So how do we recognize them? Delusions, they are fixed beliefs that are not amenable to change in light of conflicting evidence. What does it mean? In some cases, we'll have other disorder, like, for example, the obsessive compulsive disorder, in which people have intrusive thoughts, but they can be challenged to an extent if you try to rationalize them. People will continue to do their rituals, but they are able to recognize a degree of illogicity of the thought underlying them. While with the delusions, people are convinced and the thought can be criticized in spite of evidence. Patients can have a variety of themes for delusion. There can be persecution, paranoia, referential. There can be somatic, religious, or grandiose. Patients can feel like they have been taken over by an outside force. They can feel as though other people are inserting thoughts in the head, or withdrawing thoughts from their head, or in some cases they are able to read their thoughts. In case of the hallucination, as I say, the auditory are the most common in psychosis, but we can have also visual hallucination. Patients will describe different things. They will usually describe the auditory hallucination as something outside of the head, but not always. So this is not a discriminating factor. So if a patient have a voice that, according to them, come from inside of the head, that's not excluding a psychotic episode. This is something that it was used before to differentiate hallucination from pseudo hallucination in mood disorders, but it has been proved to be wrong. This is not something that can be used to discriminate them. The difference is the intensity, is how severe these and how vivid these are. So people with psychosis hear the voices as though this is an auditory stimulus present. So it's actually somebody talking to them. It can be one voice, it can be two voices talking together or commenting what they're doing. It can be a voice commanding them to do something. And obviously this is quite concerning in terms of risk to other people or risk to self. Because clearly if the voice commands them to kill themselves, to open the window and throw themselves, they might do it. And that's obviously potentially a lethal risk. Disorganized thinking is a third sign that we mentioned, and it's typically assessed through the speech. So you would hear neologism, so made up word, loose associations, clanging. So psychotic people might speak in rhyme without no much sense, because for them the sound is more important than the sense of what they're saying. Similarly, you can observe grossly disorganized motor behavior. It can manifest in different ways and also different levels. So it can be simply a fatuous behavior, or can be very unpredictable agitation. Normally, we will observe a significant difficulty for them to complete activity and perform activities of daily living. So any kind of goal direct activity will become very hard for them to perform. Negative symptoms, as I say earlier, they are a bit more difficult to identify. We can, in terms of alogia, we can observe poverty of speech or poverty of content. Affective flattening, we can observe unchanging facial expression or a decrease of spontaneous movements. For what concerns anhedonia, we can observe few interests, impaired intimacy, or a decrease in the social relationship. Avolition, it's the decrease of their will to do something. So we can observe impaired grooming, a physical inertia. As you can imagine, it's very easy to mistaken this as a sign of depression. I'm not saying that there can be a comorbid depression, but it's important to acknowledge the presence of these symptoms earlier. Same things for cognitive symptoms. There can be problems affecting attention, executive functions, memory. These should be noticed from the beginning, and they can be actually early sign. Early in my presentation, I wanted to speak about secondary psychosis. Secondary psychosis is important for different reasons. First of all, because a primary psychotic disorder, such as schizophrenia, is a diagnosis of exclusion. So all patients with new onset psychosis need a medical workup that exclude medical or toxic causes of psychosis. So I'm afraid I'll need your help again. So before I'll go into more detail. I'll check if you are still there, first of all. Are you all still there? I hope you are.
Yes, I am.
Great, Anita. So I might ask you then. I was wondering, what would you think, for example, if you have a new patient coming to your attention, is an hospitalized elderly patient that had hip surgery and is presenting with some symptom of psychosis. What would what is popping in your mind, what you be doing, what you be thinking? Would you be thinking about a primary psychotic disorder at this stage, or would it be something else that you could check? What is more probable? I will give you a help. This is an elderly patient. Could be delirium. Great, Joshua, that's fantastic. That's the right answer. 10 points to Gryffindor. Another example, and then we'll draw our conclusion. If there is an antisocial patient with polysubstance dependence that present at A&E, would you think about primary psychotic disorder, or would you be performing maybe an exam or something else before thinking about primary psychosis? Which kind of thing could you be thinking of? Absolutely, absolutely, Navdeep. So what I'm trying to prove is that in order to narrow our ideas and our suspicions, we should think about the general, all the history, but also the non-medical history, not only the psychiatric history. So secondary psychosis is any form of psychosis which is due to a non-medical illness or substance use. So here I summarize a bit, but basically virtually all the condition that affect the brain directly or indirectly might cause psychotic symptoms. So it can be autoimmune disorder or toxic, or it can be iatrogenic as well. There are some medication like the antimalarial that can cause those symptoms that we describe. Cerebrovascular disorder like a stroke can cause symptoms of psychosis. And of course, metabolic disorder and a form of epilepsy, for example, a temporal lobe epilepsy might create hallucinations. So we shouldn't underestimate the importance of secondary psychosis as a diagnosis, as a primary cause of psychosis to be considered before thinking about primary psychosis. There is not a formal suggested there is not a formal workup for secondary psychosis. The one that I put here is a sort of summary between general, very broad kind of screening that you would be performing probably in any event in a patient that access A&E, with some exams that are more specific but are very helpful because in case are positive or indicative, they suggest a condition that if treated might cause the regression of all the symptoms. Interestingly, in psychosis, in the first episode, Psychosis, there is not consensus regarding the use of brain imaging as a first port of call. It depends on each specific situation. So there is not a formal workup. So let's talk about primary psychosis now. So as I say, is a diagnosis of exclusion, and actually secondary psychosis helped us to individuate the circuit and the areas of the brain that are likely to be affected in primary psychosis too. So it's a silver lining of secondary psychosis. As the picture suggests, there are several areas that are involved in the genesis of the symptoms of psychosis. So limbic system, which is the purple one at the basis, is involved in emotion, and it's likely to be involved in contributing to the agitation that is present in psychosis. The frontal lobe, as you know, is affected in several conditions, but in this case, it's obviously critical to problem solving and insight and other high-level reasoning. When it's perturbed in psychosis, it leads into difficulty in planning action and organizing the thoughts. The basal ganglia are fundamental in regulating movement, but also in integrating sensory information. So the impact on them can contribute both to paranoia paranoia and hallucinations. And we will see how this could be also, the impact on this area can also cause the side effects of one category of the medication that is most widely used. The auditory system, so you can see in the yellow, around the temporal area, and enables human to hear and understand speech. And in schizophrenia, it can lead to auditory hallucination. The occipital lobe can be involved in the genesis of hallucination, and the hippocampus it mediates the memory formation. So obviously, when it's impacted, can lead to increased confusion, but also in the genesis of hallucination and misperception. For what concerns primary psychosis, there is no ultimate single known cause of psychosis. The model of psychosis that is most widely used at the moment is the neurodevelopmental model. As you can see in the picture, there is an interplay between susceptibility genes and early cerebral insults. So a genetic vulnerability interacts with some environmental factors that act at different stages of development. Some of these risk factors act as early as fetal life, and they can act throughout life into adulthood. So in this little scheme, it explains how the interplay between the two lead to the development of aberrant neural network that clinically are responsible to the impaired cognitive processing. And so actually at the premorbid stage, they might have an increased social isolation, inaccurate inferences about other people, but also it can play a role in the decline of functioning that we will observe often before a full-blown episode of psychosis. And then in the course of life, other risk factors will act, leading to the kind of presentation we have discussed until now, so a full-blown episode of psychosis. But this is not something that, as they believed in the 19th and actually part of the 20th century, is not a neurodegenerative disorder that starts in adult life. The psychosis was called dementia precox. It was seen as a form of dementia with an onset, a kind of early onset. It's the result of a series of insults that interact with susceptibility genes, causing a deviance from the normal development and therefore causing the symptoms later on in life. How come? So in this slide, it actually explains how this was discovered. So in 1982, there was a study by Sir Robin Murray, which is actually the kind of we can call him the inventor of this model. He described how monozygotic twins differ in their anatomy of the brain, suggesting that the one with psychosis have different anatomical presentation compared to their well-co twins. So this, although didn't dispute the fact that there was a genetic load, proved that the role of environment is crucial in the development of psychosis and opened the way to further research into this neurodevelopmental model of psychosis. So far, what are the genes and risk factors that have been proved to be involved in the onset of psychosis later on in life? Unsurprisingly, some of them are genes that are involved in the metabolism of dopamine, like the COMT. Some of them are genes that are involved in the process of proliferation and arborization of the brain, and synaptic plasticity, like neuroregulin 1, DISC1, and proline dehydrogenase actually modulates synaptic transmission. None of these genes alone confer a significantly increased risk of psychosis, but the combination of the genetic susceptibility with the environmental factor will actually determine the long-term outcome of psychosis. Nothing alone will cause psychosis. The environmental factors that might increase the risk are listed in the other table. So as I say, they can act at different stage of development. It could be as early as during pregnancy with preeclampsia. It can be prenatal exposure to infections. It can be in adolescence use of heavy use of cannabis. We are not talking about one joint, but we are talking about multiple joints, generally on a daily basis for a period, can alter development of the brain, pruning and arborization, and environmental exposure as well to some chemical is proved to be a cause of increased risk for psychosis. In this slide, we can see how from birth to the age of 25, the processes that we mentioned can be impacted. So the normal proliferation, migration, arborization, and myelination are impacted, and we can see how in the adolescent here, for example, an excessive pruning could be part of them, could be responsible of part of the deviance towards psychosis. And then later in life, the interplay between the susceptibility genes and the environmental factors cause reduced interneuron activity, excessive excitatory pruning. So this is a bit complicated, but how is this helpful to assess and manage psychosis in daily clinical practice? So thinking about the mental state assessment for psychotic symptoms, right? How can we detect sign of psychosis? So I will stop again here, and I wonder which kind of question would you ask, or which kind of thing would you observe in a person with suspected psychosis, and which kind of thing would support you in formulating a diagnosis? So thinking about appearance, what would you be noticing? Yeah. All right, Zara say unkempt, absolutely. Responding to unknown stimuli, absolutely. Direct eye contact, yes, that's yes or no, right? There are a lot of conditions, but of course something to be noticed. What about, for example, thought content and thought form? What would you be asking, or what would you be observing? Yeah, Emily, right? Absolutely. And what if they say no? I noticed nothing recently, because I think another crucial part of psychosis is that they have limited insight sometimes. So what could we be asking? I guess what I'm suggesting is that we shouldn't shy out from asking direct questions. So asking something regarding, do you think sometimes do you have the impression that you sometimes see things and the other people seems not be able to see? Sometimes people are aware to a degree that other people do not hear and see, but still they are not necessarily classify this as unusual, if you know what I mean. Another thing to be considered is that sometimes these people are very scared about disclosing because of the nature and the character of the voices. So if the voice is threatening, obviously, or commanding or derogatory, then it might be very difficult for them to share with you. So remind them the place is safe, remind them that nothing can happen to them and you are there to help. And then, you know, sometimes people have the experience of having these voices when nobody else can hear the same voices. And these voices sometimes tell people to do horrible things to themselves or others. So acknowledging that this can happen, acknowledging that that can be scary. Sorry, it looked like F5 doesn't work for me, so I'll have to every time go through all the presentation. I'm really sorry about that, and I'll be quick. So another thing that you want to assess carefully is mood, because as I say, sometimes we might mistake negative symptoms as depressed mood. So it's important both to assess if there is a comorbid mood disorder and also if we have neglected the existence of negative symptoms. In terms of thought form, the speech, we can infer the thought form disorder from the speech. So sometimes they are patients can be very tangential or use made-up word or, as I say, talking rhyme without much sense because the sound for them is more important than what they say. We thought a bit about hallucination. In terms of delusion, is again a difficult symptoms to elicit. So you can ask, I would like to ask you about unusual experience people sometimes have. That's a good way to do it. Somebody suggested in the chat. But even when people say no, please, if you have a strong suspect, go with another like more narrow question, like has it ever seemed that people were talking about you or following you, or do you feel you have received special messages, like more narrow question, because sometimes that they don't qualify these as unusual. In terms of cognitive functioning, as I say, the declining cognitive function is often an early sign. So if it's a young person, or if there is the family around, it's easier to ask. So you can ask if there has been decline at school, if their grades went decline significantly, if they have problem with concentration. This is to be noticed because it can be an early sign of psychosis. And is also, unfortunately, prognostically indicative. We will see later on in slides. So what do we do? In primary care, if we observe psychotic symptoms that last for more than 4 weeks, we shouldn't wait. We should refer to a specialist mental health service. Comes if people are less than 18, otherwise early intervention. This is particularly important because the duration of untreated psychosis has been proved to be a negative prognostic factor. So obviously, if the length is increased, then the prognosis tend to be worse. And that's a modifiable prognostic factor. So we have a responsibility here to be prompt. In secondary care, again, emphasis about a holistic approach. So full description of the current problem, but also a comprehensive medical history and physical examination is important, both as a baseline in case you are thinking about starting a medication, but also to try and operate a differential diagnosis with other condition. Psychiatric history is important to see if they have a comorbid neurodevelopmental disorder. So a full neurodevelopmental history is important. In the risk assessment, emphasis should be given to the use of drug and alcohol, because as we see, they are risk factors for psychosis, but they are also, unfortunately, a prognostic negative sign, and they are modifiable. They negatively affect prognosis in case the use persist. Social assessment, educational assessment, and occupational assessment are important to make sure that we preserve the functioning and we act as a network with other agency, making sure that the individual quality of life and functioning is preserved as much as we can. Putting the patient at the center again, we have to make sure that they have information about the diagnosis. We shouldn't assume that they can't understand. Of course, there, as we say, there might be cognitive symptoms there. There might be a decline of function. That doesn't mean that we shouldn't try to explain what's going on. That's obviously a legal requirement, because in case they have capacity, they should give us consent, but also because that improve very much their adherence to treatment. What is treatment? So thinking about treatment options, you could argue, why don't we start treating patient when we detect those early signs, when we know that there are susceptibility genes, when we know there are like several risk factors, there are some attenuated symptoms there, maybe not reaching threshold or not as long in duration. Why don't we start pharmacological treatment there? That's because these signs have been proven to be pleiotropic, so they have been proved to be present in different conditions. So we can't start an antipsychotic with all the attached risk if we don't have like a very high probability of transition to psychosis. It has been proved in different studies that although there is a percentage transitioning to psychosis when they present with some attenuated symptom or some transitory symptom, but this is 40%, so it's not a high percentage. Most of these people either don't transition or have another condition. So at this stage, what is advised by NICE is treating the condition they're presenting with and treating comorbidities. So offer CBT for anxiety, depression, emerging personality disorder, or substance misuse if they are present. If we are in front of a first episode psychosis, that's the moment in which we should start antipsychotic in conjunction with psychological intervention, both CBT and a family intervention. So we have a powerful weapon when we talk about psychosis and pharmacological treatment, and they are the antipsychotic. Unfortunately, antipsychotics are quite powerful, but they also come with high cost to making business with them, if you know what I mean. So in this table, we have some example of first and second generation antipsychotics. And as you can see, in the first column with a conventional antipsychotic, we have chlorpromazine, which was the first drug used as antipsychotic and is still in use. Other drugs you can see them listed. I won't go into the chemical family, but it's the chemical family which predicts clinical profile. However, they have common characteristics. Conventional antipsychotic are all D2 antagonists. They block the D2 receptors across the brain. Atypical antipsychotics, you can see aripiprazole, clozapine, olanzapine, and all the other in the second column. So clozapine was the first drug of the second generation antipsychotics. The pharmaceutical industry then tried to work to develop drugs with pharmacological similarities, so the same efficacy, but without side effects, because clozapine unfortunately can give agranulocytosis, so can suppress the bone marrow. Is quite important side effects, which might be lethal, is rare but can be lethal. And the management of clozapine is therefore quite complex. It requires a lot of blood monitoring, so that's why clozapine is rarely first choice. Let's have a look at the difference. So the conventional antipsychotic, as I say, they block the D2 receptors, but they also block muscarinic receptor, and this is responsible of some of the side effects we will be seeing. While the anti-conventional antipsychotic, they block D2 and 5-hydroxytryptamine 2A receptor. These differences make the categories profile slightly different. So the second generation are less likely to cause Parkinsonian side effects and extrapyramidal effects, but are more likely to produce weight gain, unfortunately. The second generation antipsychotic are also able to help with the negative symptoms because of their profile. As you can see, they link a lot more other receptor, and they can regulate mood as well a little bit better. So, as I say, what makes an antipsychotic conventional is the activity on the D2 receptor and on the mesolimbic area, so the area that was responsible in creating the positive symptoms, as we saw earlier. They block that excessive activity, reducing the positive symptoms. Unfortunately, to make it happen, they need to be blocking 80% of the receptors. And when they do, they block 80% across the entire brain. This means that they block the mesocortical pathway, which, as we said before, it's already a bit hypoactive, producing the secondary negative symptoms. So if we depress this dopaminergic pathway even further, we can increase the negative symptoms or not improve them. So that's what makes the anti-conventional antipsychotic a little bit more appealing. In the same way, they can block, and this is both of them, they can block the tuberoinfundibular pathway, so from the hypothalamus to the pituitary gland, and making so, they make so that the prolactin increase, and they can produce amenorrhea and lactation, which obviously is an unwanted symptom. In the long term, they can also act via the increase of prolactin, they can act on the bone density, and that's another side effects that we would like to not have, especially with patients that might be on this medication for a long time. The conventional antipsychotics, so first generation, as we say, they can block the nigrostriatal pathway as well. So when they block the 80% of the mesolimbic pathway, they block 80% of receptor of this way as well. And this is the way they regulate movement. So we can have akathisia, so restlessness, dystonia, so involuntary contraction of muscles, Parkinsonism, so tremors, and tardive dyskinesia, so unwanted contraction of the muscle again. The activity on the muscarinic receptor can cause the constipation and blurred vision. So quite a few side effects, but if you think about the intensity of the condition itself, overall, there might still be a benefit in using this class of medication. So as take-home points, the first generation is associated with higher risk of extrapyramidal symptoms, while the second generation is more active on the negative symptoms, but is associated with higher risk of metabolic side effects. So none of them is an easy medication to use. It has to be monitored, and it has to be the kind of physical side of things has to be monitored closely. So I don't expect you to understand this slide, especially because it's. I mean, there are a lot of medication listed. It's just to say that when efficacy was compared, almost all the 32 oral antipsychotics were statistically significantly more effective than placebo. The remaining 6 were still more effective than placebo, but the study was not larger enough to be conclusive. So although they have side effects, they have a very significant effect on positive symptoms, especially the second generation on negative symptoms too, improving quality of life and prognosis. So what about prognosis? The outcome of first episode psychosis is highly variable because, as we say, there are different conditions that can cause it. So it can range, and different people with different profile that can experience them. So they can range from early sustained recovery to antipsychotic treatment resistance. So which are the factors that can predict in a way the response and prognosis? So there are non-modifiable risk factors. So the male gender has been found to be one of them, younger age at onset of psychosis, poor premorbid adjustment, and a severe baseline psychopathology. The modifiable risk factors are interesting because these are factors where we can act on. So the longer the duration of untreated symptoms is, the poorer the prognosis is. The not adherence to antipsychotics is linked to high rates of recurrence and relapses, substance misuse and other comorbidities, and the lack of early response to antipsychotic can be also informative. There are other signs that are in the table that I attached. So the good premorbid functioning, so we can assess the intensity of the decline before the full episode of psychosis had its onset. The presence of affective features, the absence of previous past psychiatric history, the short duration of the first episode are all good prognostic factor. So what about duration of psychosis? Unfortunately, as I say, the duration of untreated psychosis is a known negative prognostic factor, and it has been proved to lead to poorer outcomes and influence the response to treatment, but also the likelihood of reoccurrence. So in case symptoms are detected, they have met the criteria in terms of time. They have been present for more than 4 weeks, and they qualify. All the symptoms for a diagnosis of psychotic episode are met. A prompt referral to specialist services should be made, and that is part of the treatment that can prevent negative consequences for the patients. Right, so I know it was a lot to take in, and I hope that some of you are still awake. I was wondering if you have any particular curiosity or question you would like to ask, or something that could be helpful for you in your clinical practice. Okay, I think there are no questions. There was something that I thought it was important to mention that is not on the slide that can be important to recognize in your daily practice, and is the malignant neuroleptic syndrome. So this is a potentially life-threatening condition and a psychiatric emergency, and it presents with fever and dysautonomic symptoms of dysautonomic function, and tachycardia and reduced blood pressure. This is something a person on antipsychotic can present with in A&E. And I thought that from your point of view as doctors, you should be able to you should be in a position of recognize this and consider it. So if a person is on an antipsychotic, a prompt recognition of this condition, and then prompt discontinuation of the medication and ICU monitoring, it's very important. So that's something that I thought it's important to mention. Since there are no questions, I will use this minute to say that. And then if there are no questions, I don't know if we want to release this student with 3 minutes of advance, Anita.
Yes, if you're finished. Thank you very much for teaching.
Okay, no problem. And then if some questions pop in your mind, please feel free to contact me. And thank you very much for coming today, and thank for interacting and be